So neurophysiology, this is an important chapter. Okay, the first topic was about cerebral blood flow. So this can be a question like an anatomical representation of the cerebral blood flow or determinants of cerebral blood flow. Questions were asked about the arterial side of that, the venous drainage of the brain and venous complications of the brain that can happen is a question also. We have discussed about venous sinus thrombosis in our neurology domain. So that's an important question that can be asked as a part question, like describe the venous drainage of brain or central nervous system and pathophysiology of venous sinus thrombosis, clinical features and treatment. So that can be a question. So just going briefly about the arterial supply of the brain and spinal cord. As a medical student, as a specialty student, you guys need to know the anatomy of the circle of Willis. Relevance of it is they can ask you about the questions such as aneurysm or aneurysmal bleed, and they can ask you about describe the anatomical distribution of the major arteries of the brain, and then they can put the second part of the question as a subarachnoid hemorrhage, and berry aneurysm or something like that. So basically, the circle of Willis is constituting all the major arteries of the brain, um, which constitutes the anterior, middle, and posterior cerebral arteries and its branches. And it should be a easy thing for you guys who should be able to draw the circle of Willis. This can be a question in the exam. Cerebral blood flow. Carotid system supplies 70% of the blood flow to the brain, and vertebral system supplies 30% of the blood flow, which accounts for around 15 ml per 100 gram of brain matter per minute, or it accounts about 14 to 15% of the cardiac output. So these numbers are better to remember and write it down on the paper when there is a question around it, because they will carry some mark. As exam going people, basic physiology and anatomy is important, so you may need to know the arterial supply and the display in the medial and lateral aspect of the brain with the corresponding arteries. So I would request you guys to at least practice these two diagram before the exam, because that can be a question like arterial supply to the brain. We talked about this question in the neurology domain earlier in the top course, but I'll go briefly about it. So there was a previous question about neuroanatomy of cerebral venous drainage and give etiology, clinical features, and features of cavernous sinus thrombosis and ICU. So a potential question that has been asked already. Venous supply of the brain is simple when you classify them into a superficial venous system and a deep venous system. The superficial venous system again constitutes the cortical vein, which is again classified into superior, middle, and inferior based on their location in the brain. And all these three major vein or venous channel drain into the superior sagittal sinus. Again, importance of superior sagittal sinus is they have the arachnoid granulation or arachnoid plexus there, which is responsible for CSF circulation in the brain. So that is again important part. The deep system again constitutes venous drainage from the subependymal and medullary region, or medullary vein and subependymal veins, which again combine together to drain into the sinuses, which is the transverse sinus, sigmoid sinus, and a straight sinus. So there are four major sinus in the brain: superior sagittal, transverse, sigmoid, and straight sinus. Ultimately, the superior sagittal sinus joins at the confluence of the sinuses along with all these three sinuses, and finally drain to the ipsilateral internal jugular vein. So that's the basic venous drainage of the brain. Now, how do you put your cerebral venous sinus thrombosis into the anatomical context is the next part of it. So cerebral venous sinuses are very peculiar structures. So the dural venous sinus layer lie between the outer or the periosteal and the inner or the meningeal layer of the dura mater. So all the venous channel lie between the dura mater, between the two layers of the dura mater, outer meningeal and the outer periosteal and the inner meningeal layer. Now, these sinuses do not have valves in them, unlike other veins, which allows free flow of blood in both direction. It should ideally flow out of the brain into the heart, but if the pressure changes are reversed, then it can flow other way around. When the brain pressure increases, the blood can flow from the brain um, into the, so usually the venous drainage is gravity related and it directly drains into the heart. But if the pressure or if there is an occlusion, there can be reversal of flow. We'll talk about that in the pathophysiology of this. There is increased back pressure due to any cause can lead to cerebral edema due to elevated capillary pressure. So the venous side of the brain, pressure in the venous side of the brain can increase due to increased backflow, which can cause edema of the brain, can cause ischemic infarction because of blood stasis in the brain. So usually this happens with the raised ICP in a traumatic brain injury where you have diffuse axonal injury, or you have a severe traumatic brain injury where because of the edema there is raised ICP and the venous drainage is compromised. Sinus thrombosis can lead to communicating hydrocephalus. So because you cannot drain the venous system of the brain, there will be communicating hydrocephalus. The CSF, outflow is not obstructed within the ventricular system, but still the venous pressure is high, so it can lead to communicating hydrocephalus. Again, a little bit of arachnoid granulation, so which secretes the CSF back to the venous sinuses, are primarily present in the superior sagittal sinus. So any thrombus of the superior sagittal sinus can cause impairment of the drainage of CSF from the brain, which can indirectly cause higher pressure in the ventricular system, causing communicating hydrocephalus. Now, a little bit of pathophysiology. Basically, there are four major things that happen with a obstructed dural sinuses. So what happens once you have a obstructed dural sinus? Again, not a single sinus obstruction can cause the symptoms. It has to be a bit patchy and diffuse to cause symptoms. So you'll have, with the obstruction of dural sinus, you'll have increased venous pressure, which can ultimately lead to increased intracranial pressure. We talked about back pressure in that. Because of the back pressure, there will be disruption of the blood-brain barrier, or destruction of the blood-brain barrier, which can cause vasogenic edema. Because of venous and capillary rupture, because of back pressure, again, smaller veins can rupture. This can lead to parenchymal hemorrhage, which usually is the presentation with a venous sinus thrombosis. And also it can cause decreased capillary perfusion, decreased cerebral perfusion, leading to failure of energy or energetic metabolism in the brain, thereby causing cytotoxic edema. So basically, any venous obstruction in the brain can lead to these four pathology, which includes vasogenic edema, parenchymal hemorrhage, cytotoxic edema. All these three things combinedly or individually can lead to increased intracranial pressure. Etiology wise, for the cerebral venous sinus thrombosis, just going quickly through that. So it is usually an inherited thrombophilia or an acquired. So it should be inherited on the right side, and it should be the acquired thrombophilia. I have wrongly written as inherited. Apologies for that. So the acquired ones can be oral contraceptive, pregnancy, antiphospholipid antibody syndrome, sickle cell disorder, autoimmune disorders such as lupus or any vasculitis, nephrotic syndrome, which is again a hyperviscous trait, can cause increased thrombosis, dehydration, malignancy, direct invasion of the venous channel. Even hits can cause that. or any intracranial hypotension like a trauma or a severe bleeding that can cause hypoperfusion to the brain can later on causes stasis of the blood in the venous channel, causing venous sinus thrombosis. Again, we saw a increased rate of venous sinus thrombosis in the COVID epidemic, up to 0.1% incidence of cerebral venous sinus thrombosis. And of course, mechanical causes, they are very important, like traumatic brain injury with a base of skull fracture, which or the fracture line going through the venous channel, then they are very prone for causing venous sinus thrombosis. Inherited thrombophilia, which has antithrombin deficiency, protein C and S deficiency, factor V Leiden, or hyperhomocystinemia. All this predisposes the patient to have a thrombosis in the venous channel. Clinical feature, again, they vary based on where they are located, but usually the patient presents with headache. It is the major symptoms, 80% chances, with associated nausea, vomiting, diplopia, inability to abduct the eye, which is a cranial nerve 6 deficit. Patient can have presentations such as the subarachnoid hemorrhage, such as occipital or neck pain. Or if the lateral sinus thrombosis is there, then it can resemble an ear infection. Sometimes the ear infection can coexist with the venous sinus thrombosis because of spread of infection through the petrous bone into the sinuses. Second common presentation can be seizure, which can be secondarily due to venous infarct. Usually it is focal, but can later be generalized. The patient can have encephalopathy, such as due to communicating hydrocephalus. We talked about that, intracranial hemorrhage or edema or herniation. Now, specific to certain venous sinuses, if they are isolatedly thrombosed, very subtle finding, very difficult to find, but you can have oculomotor palsies, you can have facial numbness, periorbital pain and headache, proptosis with ocular erythema, and if it is a septic cause to that or septic thrombophlebitis, then patient can present with sepsis and fever. This table show a gist of possible symptoms when particular sinuses are involved, but there are a very high degree of overlap. For example, sagittal sinus, 60% cases are because of the thrombus in the sagittal sinus isolatedly. They can present with elevated intracranial pressure, such as headache and papilloedema will be the symptoms. Patient can have seizures. Also, you can have symptoms which are very focal, such as aphasia or hemianopsia or hemisensory losses. So similarly, there are diffuse or there are various presentation with particular sinus involvement, but very rare or very difficult to find such presentation saying that isolatedly the sagittal sinus is involved. So you'll have these type of presentation. It is very rare because usually it comes as a constellation of symptoms. Multiple sinuses are involved. Patient usually present with a headache or fever and encephalopathy, which is unexplained, and it doesn't go with their age, because you can see in the previous slide that we discussed, the causes can be very specific, like acquired and inherited causes. So more common in the female compared to male, almost twice. Diagnostic workup, again, laboratory studies are rarely helpful. You need to rule out other causes such as CSF examination to rule out a meningitis. Imaging, there are few CT scan findings that is pathognomic of this NTD, where you can see a what you call as a dense triangle sign or a empty delta sign, where you can see there is filling defect in the suprasagittal sinus. So this is called as the empty delta sign. Then MR venography is most sensitive and gold standard. In addition to that, it can show you some edema or infarction there, which is not delineated by the CT. And DSA can be used if you cannot find a thrombus in MRI, but you are very, very suspicious of that. So in that case, DSA will be the best test to see whether if there is anything that is being missed in the CT or MRI. quickly through treatment. So immediate therapeutic anticoagulation is life-saving, irrespective of whether the patient has venous infarct or intracranial hemorrhage or isolated subarachnoid hemorrhage. The patient needs to be anticoagulated, and that's the only therapy that works well, has been studied extensively. Endovascular thrombolysis or mechanical thrombectomy, very complicated process, usually not done in most centers, but very varied outcome benefit with it. Um, so not widely studied, but anticoagulation is the mainstay of treatment, and long-term anticoagulation this patient will require, usually with a DOAC, but if the patient has pregnancy or malignancy, in that case, warfarin may be the drug of choice. Also, in case of APLA or sorry, not in pregnancy, low molecular weight heparin will be the drug of choice for pregnancy and malignancy, and warfarin for APLA and CKD patients. Going to the next aspect of that. So define how do you define cerebral blood flow? Enumerate the factors affecting cerebral blood flow and discuss the mechanism of cerebral autoregulation. So this is a very important question. And there's a pattern to remember the answer for this. So we'll go about it. So cerebral blood flow values, again, we talked about that already. Carotid 70%, vertebral arteries 30%, and overall it's 15% of the cardiac output. Cerebral blood flow, the determinant is your cerebral perfusion pressure, CPP, and the cerebral vascular resistance. Again, the CPP is the difference between the mean arterial pressure or the ICP or the CVP, whichever is greater, divided by the cerebral vascular resistance. So as you can see in this formula itself, you can tell the factors that determine the cerebral blood flow. So the most important thing to answer this question is to remember this formula. If you remember this formula, you can easily write on this question. So apart from the contributing factor, other things that can hamper or that can influence the cerebral blood flow is a CVP, which gets elevated in case of coughing, straining, vomiting, or in head down tilt position, particularly the um, um, anesthetic complication. So if the patient stays head down for a longer period of time, there is increased congestion of the brain because of increased cerebral blood flow. That can happen. Again, CVP is raised, so your CPP minus the CVP number will be less. In that case, your cerebral blood flow can be less. So either way, if the CVP gets higher up, then your blood supply to the brain decreases. If there is more head tilt position for a longer period of time, in that case, your cerebral blood flow may increase indirectly. Again, if the patient has a raised ICPs due to a space occupying lesion or a edema, again, the cerebral blood flow decreases, because the difference between the, going back to the formula. So if any number, which is ICP or CVP, increases, then this subtraction from MAP to this pressure will have a lower value, thereby decrease in the cerebral blood flow. So CVP and your ICP are inversely proportional to the cerebral blood flow. Mean arterial pressure, not rocket science. So if the patient is hypotensive, there will be low cerebral blood flow. Now, the other factors that govern is something called as the neurogenic factors. So neurogenic factors are important. So you know that there is, or we know that there is regional variation of blood supply to the brain. Some of the cortical region are better blood supplied compared to the inner non-cortical region, which is there is less blood supply. Thereby, they are more amenable to hypoxia and hypotension. Anterior circulation has more dense sympathetic innervation compared to the posterior circulation. Anterior circulation is controlled by the superior cervical ganglion sympathetic innervation, and posterior circulation is innervated by the sympathetic chain by the vertebrobasilar artery. That's why in case of a in case of a hypertensive emergency, there is selective blood supply to the brain, because the autoregulation is impaired at particular places compared to the whole of the brain. That's why we get the posterior reversible encephalopathy syndrome, in particularly in a hypertensive patient, where particular region of the brain is affected compared to the whole of the brain. The posterior circulation is more prone for such insult because the autoregulation is not that great in that region of the brain. Um, so again, new other factors that can be governed by the neurogenic factors are neurons and other cells secrete specific mediators such as acetylcholine, nitric oxide, who are potent vasodilators, and serotonin and neuropeptide Y are vasoconstrictors. So this factor comes into account if either the neurons are directly damaged or indirectly damaged because of secondary injury. So um, any injury to the brain can cause disruption of those neurons, and then they can secrete these metabolic substances that can cause direct or indirect effect on the blood flow to the brain. So that's the neurogenic factors that they govern the cerebral blood flow. Endothelial factors. So endothelium is an active organ that we know. So it produces vasodilators such as nitric oxide and also has a vasoconstrictor potency, which can be mediated through thromboxane 80 and endothelin 1. Again, based on what sort of substance is secreted from the endothelium, your response will be similar. It can be vasodilatory or vasoconstrictor based on the amount of neuromediator which are secreted, or inflammatory mediator that are secreted. Statins increase the nitric oxide synthase activity, and in experimental cases, they have to be found to have increased cerebral blood flow because they can cause cerebral vasodilatation. This hasn't been translated into practical application. This is, we are talking about vasospasm in cerebral, in subarachnoid hemorrhage, where the subarachnoid hemorrhage can cause vasospasm, and experimental evidence are there that statin can help. Statin can produce nitric oxide, thereby causes vasodilatation. But that hasn't been seen in larger clinical trial. This is only, you can say, at the experimental level where statin can cause vasodilatation. Most important is the metabolic factor, which are rapidly acting compared to any other factor. So the metabolic factors include carbon dioxide, pH, oxygen, temperature, and glucose. So with raised PaCO2 or carbon dioxide in the blood, it can cause increase in cerebral blood flow. So every 10 rise of PaCO2 can cause a 4% increase in cerebral blood flow, which is pretty significant because of vasodilatation. Again, pH regulated by carbonic anhydrase activity in case of acidemia can lead to vasodilatation and increased cerebral blood flow. Oxygen, cerebral blood flow only increases when there is a significant hypoxemia. Because of autoregulation, there is a wide range of PaO2 where the cerebral blood flow is not affected by the change in PaO2. But if it is below less than 50, the PaO2 in brain, then it can cause cerebral vasodilatation. So this is another metabolic factor. Glucose, again, severe hypoglycemia can cause vasodilatation, thereby increase cerebral blood flow. Every 1 degree decrease in the brain temperature can cause 8% or 10% decrease in the central metabolic rate, and thereby it decreases the cerebral blood flow. That's why cooling was thought to be neuroprotective, because it decreases the cerebral blood flow. So these are the major metabolic factor that determine the cerebral blood flow. So we have talked about neurogenic, endothelial, and metabolic factor, along with few general factors yet. Now the last one is the myogenic factor, where the arterioles and small arteries contract in response to increased intraluminal pressure and vice versa. So what happens is a phenomena called as a recruitment, and also a phenomena called as a like a response to the increased pressure. So if there is increased pressure detected inside the lumen of the artery, then it can cause vasoconstriction by thereby decreasing the blood going through that artery. This is a myogenic factor, so governed by the muscles and the localized neuronal connection. So mediated through the transmission of intramural pressure, activates the mechanically sensitive ion channels and protein in the vessel wall. Cerebral or autosomal dominant arteriopathy, there is something called as a CADASIL, which is a disease entity itself, in which case you lack that myogenic factor or myogenic response. So the patient will not have autoregulatory mechanism due to the mutation, which increases the chances of stroke, hemorrhagic stroke, and dementia in this patient. So it is a known entity. This you don't need to remember, but you need to know about the myogenic factors. So there are four major factors that are responsible for the cerebral blood flow, which is again majorly governed by the mean arterial pressure, CVP, and the cerebral vascular resistance. So you know the mean arterial pressure, the factors that governs blood pressure is an important part. CVP is an important part. We talked about that already. This is, and major thing is a cerebral vascular resistance. Cerebral vascular resistance is governed by these four factors, that is neurogenic, endothelial, metabolic, and myogenic factor. Now this diagram on the corner, left hand upper corner, summarizes the whole question. So if you put this diagram in your exam, you will get half of the mark. So you don't have to remember all these things. Even if you just put this diagram in the exam, if you don't have time to write all these things, this will suffice, this diagram. Very, very important. So what it shows is the pressure on the bottom, like the x-axis, and the cerebral blood flow in the y-axis. So this pressure can be different parameter. It can talk about ICP. The pressure may represent a PaO2, may represent mean arterial pressure, or a PSO2. As you can see, there are four curves going through the picture. So this is the autoregulatory range from 50 to 150 for the mean arterial pressure. As you can see, 50 to 150. That means within that range, there is no increase in cerebral blood flow. But if the blood pressure is lower than that, there will be increase in cerebral blood flow. If it is if there is lower than that, there will be decrease in cerebral blood flow, and if there is increase in that mean arterial pressure beyond 150, there will be increase in the cerebral blood flow, and the rise is pretty exponential. Similarly, for PaO2 we talked about, so there will be no change till 50. But if the PaO2 is less than 50, there will be a serious rise of cerebral blood flow, causing cerebral vasodilatation and then increase in cerebral blood flow. So this is again a very abrupt or steep rise. Higher the PaO2 beyond 200, there is some evidence that can cause vasoconstriction of the cerebral blood vessels and thereby decreases the cerebral blood flow. That's why hyperoxia can be harmful and can predispose to strokes. PCO2, again, with the rise, there's a linear relationship. As the PCO2 increases, your cerebral blood flow linearly increases. And the last one is the ICP. We'll talk about that in a different slide. So what you see is, for a constant up to a level of ICP, the blood flow remains same with the autoregulation. But if it goes beyond a certain point, then the blood flow also relatively decreases gradually, because the blood flow is the formula in the blood flow. The numerator is MAP minus ICP. So if the ICP increases beyond this number, the blood flow decreases. So this is the most important curve to remember to talk about cerebral blood flow. But I will also recommend to remember the four factors. That is important. Now discuss the mechanism responsible for autoregulation. Very important question. So basically, if it comes as a question in the exam, you need to write what do you mean by autoregulation. So autoregulation is a homeostatic process that regulates and maintains cerebral blood flow constant across a range of blood pressure. We talked about that already. Now the range is a mean arterial pressure of 50 to 150 or 60 to 160, you can say, and a CPP of 50 to 150. So this is the range where the autoregulation is maintained for the blood pressure. Now mechanism, we talked about that: myogenic, neurogenic, metabolic, endothelial. So if this question comes, this is the pattern how you answer. Now assessment of autoregulation. So this can be a question. It is a complicated physiological understanding there. So there are two measures. We call it as a static measure and a dynamic measure. So the static measures is that drug administration to change in MAP without affecting the metabolism. So what happens is we give a drug to the patient to increase the MAP, and thereby we look at the change in cerebral blood flow. Thereby, if the cerebral blood flow is maintained within a range of the mean arterial pressure or systolic blood pressure or the cerebral perfusion pressure, any pressure within a range, then you know that the cerebral autoregulation is intact. But if it is not, then it is not intact. So you get a baseline map of the patient and you infuse a drug to increase the blood pressure. Then after some time you measure another blood pressure. So corresponding two values of cerebral blood flow at the same time is measured. And the change in cerebral blood flow in relation to the map is indicative of the cerebral autoregulation. So we call it as an autoregulatory index, or ARI. ARI is representative of percentage change in cerebral vascular resistance to percentage change in cerebral perfusion pressure. The value stays between 0 to 1. So if there is an equivalent resistance as cerebral perfusion pressure ratio change are equivalent and the ratio is 1, that means the autoregulation is maintained. But if it is 0, then there is no autoregulation, and between 0 to 1 means there is somewhere impaired autoregulation. So again, this is a theoretical experimental number that we look for. Clinically, it is not used, at least where I have worked, hardly we use it looking at these numbers. But the question in the exam can be like, if you're talking about the physiology, then they can ask you about how do you measure the cerebral autoregulation. In that case, you need to know a little bit of this. Now, the dynamic measures the dynamic changes in cerebral blood flow in response to dynamic changes to map. So cerebral blood flow should return back to original value within a specific time, even if the cerebral blood flow changes with abrupt changes in the mean arterial pressure. That should change on its own to its baseline. Even if, suppose for example, you increase your map to 150 to 180, there will be a transient rise in the cerebral blood flow for some time, but again the body will accommodate that and it will come back to the same level of cerebral blood flow within a short period of time. So that's why there is a dynamic change. If the dynamic change is intact, that means your cerebral autoregulation is intact. But if it is not intact, then with an increase in the map, you will have a higher blood flow into the brain. So those are the dynamic measures. Usually we call it, or we do it through a high cuff method, where cerebral blood flow is measured by the transcranial Doppler. So they will inflate the cuff in the thigh and initially see if there is an increase in the blood flow into the brain. If the blood flow into the brain stays increased for a length of time, that means there is no autoregulation, or there is lack of autoregulation or impaired autoregulation. But if the blood flow again comes back to the baseline in spite of the tourniquet, then you know that there is an intact autoregulation. So the static measures and dynamic measures. Clinical uses of autoregulation testing, as I said, usually not done clinically. Perioperative management of patients undergoing cardiac endarterectomy, you can think of doing it more of a clinical judgment rather than we put in devices to look for the cerebral blood flow. Blood pressure management in uncontrolled hypertensive patients, that can be used, and blood pressure support in patients with carotid artery stenosis. So again, this is an important or interesting physiological variation. So if the patient has significant carotid artery stenosis, their autoregulatory range is very narrow. If you drop their blood pressure or map below 50, they will be obviously unconscious. But again, that lower level is pretty higher for them. So like their autoregulatory range will be between 90 to 120 of map. So you have to have a map of 90, otherwise they will have neurological symptoms and stroke. So as you have more stenosis of the carotid artery, the autoregulatory range can be narrowed. So it is an important aspect when we are doing vascular surgery to monitor brain perfusion on both sides while operating on the carotid artery. So there are different measures to look at. Some center do central oximetry, some center do Doppler. All those things can be done, but the measurement of static or dynamic measure of autoregulation in a what do you call continuous measurement is still not in the clinical practice as yet, but that can be asked in the exam. What happens if you lose your autoregulation? That is the following question. Either you can lose your autoregulation, um, which can cause different effect, like what is the outcome of what can happen to a patient if they don't have a um, intact autoregulation. So usually in traumatic brain injury, the autoregulation is absent or impaired. Even the cerebral perfusion pressure or cerebral blood flow is normal. So what happens is, if you have a disruption of the autoregulation due to anything, usually it is a secondary brain injury that causes it. You can have, or you can maintain a good blood pressure, you can maintain a good cerebral blood flow, you can maintain a good cerebral PO2, but still if the auto regulation is impaired, then the patient can have worse outcome. um, Usually in traumatic brain injury, there is cerebral hypoperfusion, either um, due to the sedation or the coma the patient has. So if you sedate the patient, there is less cerebral metabolic requirement, and you can have less blood supply to the brain, causing less perfusion or cerebral blood flow into the brain, or it may be due to the hypoperfusion or shock causing ischemia. So suppose traumatic brain injury having a hemorrhagic shock, in that case also there will be less blood supply to the brain. So these are the two factors that can cause a hypoperfusion state to the brain, which is in literally the less cerebral perfusion pressure, less cerebral blood flow, which can cause ischemia, and that can cause exacerbation of secondary brain injury, that can cause the loss of autoregulation. So all the pathological process happening in traumatic brain injury or any sort of insult to the brain, whether a stroke or a subarachnoid hemorrhage, can be explained in terms of brain injury due to low perfusion state, which can be due to either ischemia or metabolic injury. We'll talk about that in few more slides. So basically the outcome of loss of cerebral autoregulation is exacerbation of secondary brain injury. It is a vice versa process. Loss of autoregulation can cause exacerbation of secondary brain injury. Again, secondary brain injury can cause loss of cerebral autoregulation. Then there was a question about CSF, just changing gears. So formation, circulation, and function of cerebral spinal fluid. Again, these are very solid questions to score, because the fact doesn't change in this physiology question. You need to have your understanding clear about it. So we'll talk about formation, secretion, absorption. So all three things come together. The rate of CSF formation is around 500 to 600 ml per day, and it is churned about 3 to 4 times in a day. So the circulation time is 8 hours. So within 8 hours, the whole of the CSF gets changed or gets circulated through a particular region of brain. So 3 times a day. Choroid plexus forms around 70%, ependymal wall or ventricles forms around 30% of the CSF. Plasma is filtered across the fenestrated membrane of the choroid capillaries endothelium via bulk flow or ultrafiltration. So this is the mechanism how the CSF is formed along the hydrostatic pressure gradient. So the formation of CSF is more or less due to the hydrostatic pressure changes, due to the gradient that is created. That's how the CSF is formed. The constituents of CSF, again, it is an important question. If you know it, you can write it, you cannot bluff it. So electrolytes in the CSF, sodium enters the CSF and potassium leaves the CSF actively against their concentration gradient. Chloride and bicarb move passively into the CSF down their concentration gradient, and water moves from the plasma into the CSF due to osmotic gradient. So the major constituents are electrolytes, sodium, potassium. They move against their concentration gradient. That's the active process. The negatively charged ion, chloride and bicarb, move passively in the CSF along their concentration gradient, and water goes through the osmotic gradient. So this is how the CSF is formed. If you write this much, that should be enough. Glucose enters the CSF by the facilitated transport. So glucose, to be sure, all over the body, it cannot transfer on its own. So it has to be a facilitated transfer always for the glucose. So you can write this sentence in any form of formation question. So how CSF is formed? So glucose enters the CSF by facilitated transport. Protein enters the CSF via vesicular transport across the cell, but some enters through the tight junction and via extracorporeal site. So this is important because you will have a very low amount of protein in the CSF because of this mechanism. If you have inflammation, that can cause leakage of protein into the CSF1 or secretion of protein into the CSF2. So these are two reasons why you will have a high protein in any type of CSF insult, whether it is an infective or a non-infective causes such as malignancy or even trauma, subarachnoid hemorrhage. All these things will have a high protein in the CSF. This graph again very important. If there is a formation or CSF physiology question, make sure that you draw this graph. So the graph we talked about in the autoregulation and this graph, these are the two important graphs to remember in CSF physiology or brain physiology. So on the y-axis is the CSF volume, on the x-axis is the pressure. Again, you can see there are two mechanisms, absorption and production. So the production remains the same throughout the ICP. If the pressure increases, the production still is same to a particular level, but most of the range of the ICP, intracranial pressure, the production remains the same. But as you go higher on the intracranial pressure, initially within a physiological range, the absorption is balancing the production. So whatever you produce, that gets absorbed. But as the ICP increases, there is more pressure on the system to absorb more CSF. So then here the CSF absorption becomes exponential till a value where the pressure is too high, and then nothing can happen, like everything shuts down when the patient is brain dead or there is malignant intracranial pressure. So this is important. The production is not affected by the intracranial pressure. The absorption is linearly increased after a physiological range of ICP. This is important to remember. Okay. Now, determinants of CSF formation, we talked about that. So for a CPP of more than 70, there is minimal change in CSF production rate. But if the CPP is less than 70, then the CSF formation also decreases due to secondary decrease in cerebral blood flow. So this is general understanding. If there is less blood going into the brain, there is less production of CSF. Absorption, again, absorption 90% is through arachnoid villi and less 10% through the cerebral venules. So production is 70-30 through the choroid, and ependymal ventricle is the secretion part. Choroid 70%, ependymal wall 30%, and absorption is 90-10. Arachnoid is 90 and cerebral venules are 10. Determinants of CSF absorption, we talked about that already. Now, circulation, CSF flow plus. So CSF flow is generated by the ciliary movement of the ependymal cells. Respiratory oscillation and also arterial pulsation cause CSF movement. How do you know that? If you transduce a CSF pressure, you will have the similar waveform as that of a arterial waveform. So there is impulse that is generated from the artery into the brain parenchyma and also into the CSF space like the ventricles, where the pressure corresponds to the changes in the blood pressure. Thereby the same dynamics happens. So the CSF is also propelled into the system or around the system by the changes in the pressure. Respiratory oscillation also, because respiratory oscillation also varies our pressure, also varies our CVP, that can indirectly affect the blood supply to the brain. Within the ventricular system, from the lateral ventricle to the third ventricle via the interventricular foramen, this is the circulation pathway. Then both the lateral ventricle come to the fourth ventricle via the cerebral aqueduct, and then to the subarachnoid space through the cisterna magna via the foramen of Mazzenti and Lusca. Lusca, L for L, lateral is Lusca, foramen of Mazzenti is medial in position. It then circulates in the subarachnoid space surrounding the brain and spinal cord. So that circulation happens 3 times a day. Now, functions of CSF, very easy to answer, solid question, and you'll get total mark if you know the points how you answer it. So it has a protective role. So water acts as a water bath. So CSF acts as a mechanical cushion to prevent brain injury associated with acceleration or deceleration forces secondary to changes in head position or direct head trauma. Because of the low specific gravity of the CSF 1.007, so the effective brain weight is reduced from 1400 gram to 50 grams because of the CSF. When the brain floats in the CSF, then the weight of the brain gets less, so that if there is a acceleration or a deceleration process, there is less impact on the brain. It works as a buffer, so buffer for the pressure. So acute increase in ICP associated with acute space occupying lesions or any bleeding or anything that happens acutely. This is again translocated by displacement of the CSF from the intracranial space into the extracranial, like the spinal cord space, or from the brain into the spinal cord if there is an increase in pressure in the brain. It maintains the constant ionic environment. It supplies nutrition. It is responsible for excretion of toxic substances. Though there is no lymphatic system in the brain, but it works as a lymph for the brain. It manages the acid-base status of the brain, and it has also endocrine function, transport hormones to other part of the brain. So these are the points for function of CSF. Now going to the third question. So if we are talking about CSF, we'll talk about intracranial pressure. So sometimes what happens is people get confused in the exam. They will ask about enumerate the factor determining the formation of CSF, and people start writing about factors governing the ICP. Though they are overlapping, but they are not the same. At least when you are writing, it should not be mentioning vice versa. So if they're asking about CSF, talk about CSF. If they're asking about ICP, write about ICP. The factors are overlapping, but not common. So we'll talk about intracranial pressure now. So physiological factors that determine the intracranial pressure. Explain briefly how intracranial pressure is regulated. Discuss intracranial pressure dynamics in patients with brain trauma. All right, intracranial pressure, again, definition is the hydrostatic pressure within the cranial vault, which is around 5 to 15 millimeter of mercury. The physiological determinant of ICP is governed by the Munro-Kelly doctrine. So important again, if it asks for this in the exam, it is a solid answer, because if you know, you can write, you can get the full mark. So in adults, the rigid and the closed cranial vault forms a fixed brain volume that contains brain, CSF, and blood vessel. So brain parenchyma accounts for 80%, CSF accounts for 10%, and cerebral blood and blood vessels count for 10% of the volume. So any changes in the volume of any of these components will alter the volume of one or more of the other component of the cranial contents. And this compensation happen to a particular range, beyond which further compensation will not happen, will cause an exponential rise in the intracranial pressure. So that's the Monro-Kelly doctrine. So ICP determinants. So there are three factors: brain volume, CSF, blood volume. Now brain volume, again, brain volume means mass of brain, but there can be additional masses such as tumor, such as blood, cysts, abscesses, etc. that can increase the brain volume. Brain volume, then second part is the blood. That means, as I talked about, any hematoma, extradural, intraparenchymal, subdural hematoma, that all can cause an increase in brain volume. And edema. Edema is usually missed as a part of a brain volume, but this is an important part. In trauma or any inflammation to the brain cause significant edema, which can cause an increase in brain volume effectively, because edema means accumulation of water. Then the second important structure in the brain is the CSF. Again, CSF is governed by the production and absorption. So here the CSF comes. If the question asks about ICP, you have to talk this way: brain volume, CSF, blood volume. If the question asks about CSF, then you can talk about production and absorption. This is the overlapping factor here. So production is governed by multiple factors. That graph needs to come here, the flat CSF production curve with the pressure, but an equivalent or a linear increase in the absorption rate if there is an increase in ICP. So that graph needs to come here. We talked about that. So if the CPP is less than 70, there is less production of CSF. If the CPP is more than 70, there is no effect or constant production of CSF. Absorption again is based on ICP. If the ICP is low, there will be normal absorption. But if the ICP is high, there is linear increase in CSF absorption. The third point is the blood volume, which is mainly determine the cerebral blood flow. We talked about the factors governing the cerebral blood flow. Can anybody tell what are the factors we talked about? Any volunteers for that? All right, people try to keep quiet. That's good. Okay, blood volume, again governed by the cerebral blood flow.
There is one answer, Sanant.
Yeah.
GBP and CPP. What does Josna? What are you trying to mention here? Okay. Okay, you can go ahead. Yeah.
Okay, sure. We talked about this. Cerebral blood flow is governed by multiple factors, the myogenic factor, neurogenic factor, metabolic factor, all the four factors. So the cerebral vascular resistance is governed by those four factors. The other factors that is important is the temperature and cerebral perfusion pressure. This is the blood pressure and temperature is an additional factor. So those four factors will come here. Cerebral vascular resistance, cerebral perfusion pressure is based on blood pressure, CVP or ICP, and temperature is an independent factor. All right, talked about that. Again, CVP and ICP increases with cough, sneezing, vomiting that can alter your ICP. Cerebral vascular resistance, PO2, PCO2, that graph we talked about earlier, that will come here as an answer. Now describe the consequences of raised ICP. So initially there is compensation, there is this redistribution of CSF in the brain. If the pressure increases in the brain, so CSF is displaced to the spinal subarachnoid space and or increased reabsorption rate, both happens. But later on, once there is decreased cerebral blood flow, secondary to decreased cerebral, secondary to raised ICP, then it can cause cerebral ischemia, because if the pressure inside the brain increases, there will be less blood going into the brain. In very late stage, where the decompensation point is achieved, in that case, there is abrupt rise in ICP and there is quick decrease in the cerebral blood flow to the extent that there is no flow. That's how we detect the brain death. We look for a no flow state in a flow flow evaluation to see if there is doubt in brain death testing. That's why we send patient for either 4-vessel angiography or a isotope scan of the brain or flow scan of the brain to see if there is any blood going into the brain. So this is the decompensation point where the pressure is too high to allow any blood supply to the brain. So that's the consequences of raised ICP. All right, going to the next question. Pathophysiology of metabolic brain injury. Again, this is a very theoretical question that can come. You need to know certain points about it. You don't have to know in and out of the whole pathophysiological process in brain injury, but need to know few points to write in the exam. So discuss the mechanism of neuronal death and secondary brain injury, head injury pathophysiology. So this is important because TBI, traumatic brain injury, is very important. The whole question will be partitioned, like describe the pathophysiology of traumatic brain injury. How do you manage a traumatic brain injury? So part of that is clinical, part of that is theoretical in the exam. So for the theoretical part, you need to know few things to write down. Now, brain injury is classified into primary and secondary. primary brain injury is what insult has happened to the brain, which includes either intraparenchymal injuries such as a diffuse actional or a contusion, or intracranial hemorrhage such as subdural, extradural, or subarachnoid hemorrhage that can cause secondary brain injury. All of that can lead to secondary brain injury. Also, pathologies such as hypoxia, ischemia, or an infection which can cause secondary brain injury because of either hypoperfusion state or hypoxia state or inflammatory state to the brain. So you need to know or have a clear idea about what do you mean by primary brain injury and what do you mean by secondary brain injury. So the care of neurotrauma patient is focused on to prevent ongoing secondary brain injury or transformation of primary brain injury to secondary brain injury. That's why the treatment is prevention of secondary brain injury in brain trauma patient. Now, pathophysiology. So primary brain injury is straightforward. Either you hit your head, or there is a hemorrhage to the brain, or there is an infection to the brain. Okay, that's the primary brain injury. Secondary brain injury is the main part that determines the prognosis of a brain injury. There are different stages of secondary brain injury in a traumatic brain injury. This is talking about the traumatic brain injury, what happens. So there are stages of secondary brain injury, which is called as acute phase, subacute phase, and a chronic phase. Now, acute phase, due to any insult in the brain, ultimate final pathway is a hypoperfusion or low blood supply or a ischemic change to the brain. So either there is a metabolic failure because of direct injury, or there is a hypoxia to that part of the brain that is governing the acute phase of the injury, that is within hours to few days, acute phase of the injury. So usually what happens is you have two phenomena that happens. One is lack of energy because there is a metabolic failure. The other one is something called as a excitatory injury, which is very important. So glutamate and arachidonic acid metabolites. So these are the two metabolites which can cause your excitatory injury to the brain. So the neurons are self-firing cells. Because of injury or irritation, they keep on firing, which is called as a excitatory injury, which is mediated majorly by the glutamate. What happens after that? If there is repeated hyperexcitability or hyperexcitatory state, there it leads to neuronal injury and subsequent neuronal death. That's why we treat any seizure activity very, very acutely. Suppose somebody has a convulsive or a non-convulsive seizure, we have to treat it because it is a excitatory injury to multiple neurons. If it keeps on happening for a longer period of time, there will be irreversible damage to those neurons, causing neuronal death. So that's the path how the excitatory injury to the brain happens. The second part, as I called, is a metabolic failure, where you have lack of energy due to ischemia, there is less ATP, there is disruption of normal iron gradient and increased calcium influx. So all the what do you call destructive pathway in the body goes through calcium. There is at the end there is increased calcium influx into the cell. So always write about increased calcium influx into the cell, thereby causing mitochondrial dysfunction, or vice versa. Mitochondrial dysfunction can cause increased calcium influx into the cell, thereby cell death. So acute phase has two components. One is excitatory, one is due to energy failure. These are the two components of that. Subacute is more what we know about, right? Either it is because of inflammation, either it is because of apoptosis, either disruption of blood-brain barrier or cerebral edema, or all together, right? So there are at least four different types of mechanism that constitute a subacute phase of injury in a traumatic brain injury, secondary brain injury. Primary, you forget about that. You have injury directly to the brain, or there is a hematoma or something. So the primary is not a big deal. The secondary is the main thing. Acute phase we talked about. The subacute phase is governed by inflammation, apoptosis, disruption of blood-brain barrier, and cerebral edema. So inflammation, again, you need to talk about activation of glia cell, microglia cell, leukocyte infiltration, mediators such as all the inflammatory mediators, you can name them, interleukin 1, TNF alpha, etc. Apoptosis, Again, pro-apoptotic mediator is BCL2 and other Fas ligand, capsase 3 or cytochrome C. These are the mediators for the apoptosis. There is apoptosis that can cause secondary or subacute phase of the secondary brain injury. All of these can cause disruption of blood-brain barrier, which is a predominant finding in case of traumatic brain injury or ischemic reperfusion. If there is ischemic reperfusion, again, because of disruption of blood-brain barrier, there is ongoing insult to the brain. All these things can lead to cerebral edema due to increased vasodilatation through the nitric oxide pathway and other pathways. So the headings of this is important. The subacute phase happens because of inflammation, apoptosis, disruption of blood-brain barrier, and cerebral edema. The acute phase happens due to two mechanisms. One is excitatory, other one is energy consumption or exhaustion of the energy. So if they ask about pathophysiology of brain injury, that's how you write. Primary, secondary. Secondary is acute, subacute. Acute has two mechanisms. Subacute have multiple four mechanisms. Okay. I think this is the last one we'll talk about. Cerebral edema. Again, they can ask about the pathophysiology of cerebral edema, type of cerebral edema, and management. I think all of us know about the management of cerebral edema who is working in a neurotrauma unit, but the main thing is to how to put it on paper. Cerebral edema, what are the types of cerebral edema? Now, there are at least three known type of cerebral edema: vasogenic, interstitial, and cellular. So vasogenic is increased permeability of the capillary endothelial cell. So increased permeability of the endothelial cell causing vasogenic edema. There is an existing incompetent blood-brain barrier which causes influx of protein from the intravascular space through the capillary wall into the extracellular space. It predominantly affects the white matter. So vasogenic is an incompetent blood-brain barrier. Now, cellular or cytotoxic is seen in head injury and hypoxia. This is because of swelling of glia cell, neurons, and endothelial cells due to release of toxic factors from the neutrophils and bacteria. Cytotoxic edema usually affects the gray matter. So vasogenic is white matter, cytotoxic is usually the gray matter involvement. Something called as the interstitial edema, which is, you can see, usually reported as what do you call, periventricular soiling or periventricular edema in the CT scan report. That's what is called as the interstitial edema, which is due to the hydrocephalus. There is CSF outflow is obstructed. There is increased intraventricular pressure. The pressure inside the ventricles are high. So there is movement of sodium and water across the ventricular wall into the paraventricular space. That happens. It can be seen in meningitis, where there is obstruction of normal CSF pathway. You will have foramen of Monro is blocked, or there is a obstructive hydrocephalus that can cause increased resistance to CSF outflow, thereby increasing the pressure inside the ventricle. So there is more seepage of water and sodium into the periventricular space, which is causing interstitial edema. But pathologically, the vasogenic and cellular are the most important type in case of a traumatic brain injury. Now, etiology of cerebral edema, there can be multiple. Sometimes people miss about the non-neurological causes. So this is the one why I want you guys to focus. Neurological is easy. Anyone can write. So ischemic stroke, hemorrhage, brain tumor, meningitis, encephalitis, other brain infection, etc. can cause neurological causes of cerebral edema. But what are the non-neurological causes? This is important because the examiners want to see whether people know about it or not. So diabetic ketoacidosis, particularly in a young kid, is very, very important. So they have a significant morbidity due to cerebral edema and decay, particularly in young kid where the blood-brain barrier is not that mature. They have young brain. So any changes in the osmolality or glucose level very quickly can cause significant brain edema, or as such, ketone bodies can cause significant brain edema in diabetic ketoacidosis. Lactic acidosis, malignant hypertension, we talked about the Press syndrome, hypertensive encephalopathy, fulminant viral hepatitis, hepatic failure, Ray's syndrome, carbon monoxide poisoning, hyponatremia, SIADH, opioid abuse and dependence, some sort of bites of reptiles and marine animals, and also high altitude cerebral edema. So all these are examples of non-neurological conditions of cerebral edema. Pathophysiology, again, as I told, so this is the standard way of answering. Brain, there is excitatory glutamate, there is opening of calcium and sodium channels, inexpensive energy by ATP pump. So there is ATP exhaustion that can cause the pathway of less ATP to the cells, thereby the cell starts to die. And also there is influx of calcium accumulation that can promote the apoptosis and thereby causing further edema of the brain, and also direct injury to microglial cells and activation of microglial cells causing release of inflammatory mediators. So the pathophysiology pathway that I showed earlier, that also accounts for here, but you need to modify your answer a little bit to suit the cause of cerebral edema. Management, they can ask, this is, we talked about earlier about this, not in this class, but earlier in neurology domain, but the mainstay of treatment for cerebral edema is diuretic. Diuretic and osmotherapy. These are the main two stay of treatment, but some additional treatment that can be done in acute settings such as hyperventilation, and particular causes of cerebral edema can be responsive to corticosteroid. Let's talk about that. So diuretic usually has been shown to prolong reversal of blood-brain osmotic gradient established with the osmotic agent by preferentially excreting water over solute. So they cause more aqua diuresis or water diuresis if you use a loop diuretic. In that case, you retain your electrolytes compared to the water, and thereby it can cause reduction in the edema. Corticosteroid, again, chronic meningitis and in acute bacterial meningitis under cover of antibiotics. So in those cases, acute bacterial meningitis, tubercular meningitis, in those cases, steroids are mainstay of treatment at the beginning. Malignant brain tumor, you know that already. It is an important part of treatment in case of brain tumor associated raised ICP or post craniotomy for any tumor, etc. In that case, steroids are important. We do use it frequently in those patients. And as an adjuvant to the chemotherapy for CNS tumors, so lymphomas, etc., they are very responsive. So in those cases, steroids are mainstay of treatment. We talked about perioperative brain surgery. Hyperventilation recommended only for short term for control of ICP, as effective in sustained, as the effect is not sustained and there is rapid equalization or there is rapid homeostasis, thereby the effect of hyperventilation gets reversed because of the body's accommodation, but it can be used as a urgent measure to control acute rise in ICP. It causes cerebral vasoconstriction. It can cause direct cerebral ischemia if the CO2 is kept less than 25 or 25 for a prolonged period of time. So usual recommendation is only mild hypocarbia, like in the range of 35 to 40, that's fine. But if you acutely need to reduce your ICP till you have other definitive measure, then you can hyperventilate the patient up to 30 or less than that for only a limited period of time, knowing the risk that it can cause cerebral ischemia. Other measures include barbiturate. That's again reduces the cerebral metabolic rate and subsequently reduces the blood flow and ICP, thereby thinking that with the low blood flow, there will be less edema. Surgical, again, this is the, if there is something that is causing pressure and causing edema of the brain that needs to be released, needs to be done, decompressive craniectomy and osmotherapy. We'll talk about a little bit about osmotherapy. So how does osmotherapy work? So what happens is, again, the primary aim of brain trauma or brain protective measures are to prevent secondary brain injury. Now, secondary brain injury can happen due to either increase in blood volume in the brain or either increase in ICP in the brain, or if there is a space occupying lesion, right? So in those cases, hypertonic saline or what you call osmotherapy, whether it is hypertonic saline or mannitol, can be very, very useful. What it has shown is mannitol works to reduce the vasogenic edema, and also it reduces the blood viscosity, thereby increases the microcirculatory flow through the pia arterial constriction, thereby decreases the cerebral blood flow. So mannitol can directly cause improved blood supply to the smaller arterioles by decreasing the blood viscosity. It reduces the blood flow into the brain, like the effective cerebral blood flow can be reduced, and also it reduces the vasogenic edema. But when you look at the benefits of hypertonic saline, it has multiple other benefits along with the same as the mannitol. So what happens is hypertonic saline works both in cytotoxic and vasogenic edema. How does it work? So it increases the aquaporin 4 expression, thereby downregulation of glutamate transporter. So the inflammatory or the excitatory pathway of the brain edema is negated by, to some extent, by the hypertonic saline. Second part, it reduces the TNF alpha, thereby which TNF alpha triggers the capsis 3, which is the apoptosis mediator. It reduces that. So the chances of apoptosis or rate of apoptosis also decreases. It also decreases interleukin 1 beta, again that reduces the apoptosis. So it has a more of an anti-inflammatory mechanism also, along with the reduction in vasogenic and cytotoxic. But unfortunately, there is no head-to-head trial for hypertonic saline to mannitol in a large scale. So that's why the current standing brain trauma foundation doesn't give you a preference of one over the other. So going as a comparative thing between the hypertonic saline and mannitol, so what happens is both hypertonic saline is superior to mannitol in control of ICP by easy and sustained effect. So it can cause a more sustained effect than compared to the mannitol. There is less chances of treatment failure. This is well documented in the literature. So if you fail with mannitol, sometimes in that case, hypertonic saline may be beneficial. It does work. And it controls ICP in cases where mannitol has failed, that I talked about already. And the important thing is mannitol cause significant diuresis. The patient may be intravascularly dry, thereby compromising the blood supply to the brain. But this is not so common with hypertonic saline. So you don't have to bother about chasing fluid into the patient. One way you are trying to decongest the patient to reduce the ICP, and the other way you are worried about the volume status. So that is not so with use of hypertonic saline. Theoretically, it is better than the mannitol, but as I said, there is no large-scale trial to compare head-on both of them. Now, what are the cons? So, if you use hypertonic saline, there is rapid changes of serum sodium. There is risk of central pontine and extrapontine myelinolysis, which is a potential practical risk. But there are many cons with mannitol. So, what happens with diuretic? It can precipitate AKI because of dehydration. There may be local brain edema or rebound increase in ICP due to the accumulation of osmotically active molecules in the brain where the blood-brain barrier is disrupted. So what you call refractory or rebound local edema or local brain edema has been found as a consequence of mannitol. Both of them can cause initial volume expansion on rapid infusion, which can cause a precipitated heart failure in a borderline patient and pulmonary edema. So both of them can cause pulmonary edema. Abrupt discontinuation can lead to rebound intracranial hypertension, which is correct for both of them. So this is important. This table is important if they can ask you about compare and contrast between hypertonic saline and mannitol. As I said, Brain Trauma Foundation quotes a retrospective observational study with an increased ICP burden, that is number of days with a raised ICP more than 25 millimeter of mercury, and length of ICU stay in mannitol group. But the mortality difference was not significant when they compared with hypertonic saline. So the control and the length of ICU is less with hypertonic saline, but there is no mortality benefit. In a RCT of 47 patients, documented better ICP control with hypertonic saline compared to mannitol. So there is scarcity of good randomized controlled trial in this aspect. That was my last slide. Thank you for your patient listening.